So this guy, you know Juan Guerra? Juan Guerra? Okay, he's a bachatero from Dominican Republic, okay? So Juan Guerra, I call this patient Juan Guerra, I changed his name to Juan Guerra. Juan Guerra is the most famous singer from the Dominican Republic from a Jewish white guy's point of view, okay? So you could check him out. So we have this prison unit at Bellevue. If you go to the 19th floor at Bellevue, you enter the Department of Corrections, and you're on a prison unit. There's 100 prison beds at Bellevue. I highly recommend you guys go because it's a really fascinating experience. So you guys know Rikers Island's got 11 prisons. Each prison has a capacity for about, I'm just giving you some ballparks, it's not exact, but about 2,000 people. So it holds about 20,000 prisoners at Rikers. One prison is just for women, and then the rest are for men, and they're divvied up for different kinds of issues. But Rikers Island doesn't have an enormous range of capacity for medical problems. So it has an infirmary and a short-term unit where you can stay for a night or two. Now remember, the people that are in Rikers, a lot of them are just in pretrial detention, but the other people are there sentenced up for a year, and then they go up to, if it's more than a year, they usually go to other prisons north of the city. But the issue is that the people in Rikers are generally quite sick. They have mental issues. Remember, we described the prison system is the de facto mental hospital for the country. A lot of them have addiction problems. A lot of them have HIV. A lot of them have C. A lot of them have a lot of social issues. So it's a heavy-duty place. A lot of stuff going on. A lot of chronic illness. A lot of acute stuff on chronic. A lot of drugs. So if patients get sick at Rikers, they get taken to the Bellevue Hospital. If they're men, and if they're women, they go to Elmhurst Hospital. A fair amount of women who are prisoners there deliver babies during their time there. And if they're not drug addicted or abusive, they can actually keep their babies. So in the prison for women, there's actually a nursery for newborns. So I go up to the 19th floor to see the prisoners once a month. I make rounds. One of my friends takes me around the medical unit, and another person took me around the psych unit. Psych unit, by the way, the sickest patients in the hospital, without any doubt. So this chapter is called the one strike law. You guys have all heard of the 3 strikes and you're out law. This is the one strike. These people don't get 3 strikes and you're out. They get 1 shot, and that's it. So I go up there, and I see this guy across the room. We're making rounds. All the prisoners pop out when I go up there, and because it's so boring. If they can walk, they want to get out and chat with people. It's just asphyxiating. A lot of prisoners like to go to Bellevue to get transferred just for a change, and it's safer than it is on Rikers Island. So I see this guy across the room. He's about halfway over here where this young lady's taken, and I knew what his problem was right away. I could see he was a skinny Latino guy, pepper gray hair, and he had these 3 bulging golf balls in his right neck. I knew his diagnosis and I knew his treatment. So we gradually made his round around there, and I started chatting with him. I got to know him, and I got to know him really well over the next year. I saw him a lot, met his family, his wife and 2 kids. He was a really nice guy, very, very mild mannered. Been in and out of prison probably for 25 years under. He was about 52, 53. And so first let me tell you about his diagnosis. First of all, these 3 golf balls in his neck were cancer. He had throat cancer. And he had what's called squamous cell carcinoma of the throat. And he needed radiation, he needed chemotherapy, and then he needed surgery. It's a really big deal. And the vast majority of people with that stage, what he has, probably had a 25% chance of living. The reason it was so advanced was because he'd been in the prison system. There were so many delays in getting him diagnosed and getting his treatment started that it went from stage a little past 1 to stage 3. The other thing, I got to know him, and he was one of the guys that got me interested in mass incarceration, this whole issue that, when you guys are becoming experts and your faculty are really super knowledgeable about this, I said, Juan, tell me your story. We got to know him. I got to know him pretty well. And I got him out on compassionate release, and we ended up on the regular floors. But the issue was, how did you get, what was your first date with the criminal justice system? And why are you still here? What is going on? So, when I was in medical school, I got number 4 in the lottery. There was a lottery during the Vietnam War, okay, back in the 70s, early 70s. Vietnam War ended in 1975. I got number 4. If I wasn't in medical school, it would have been in the Mekong Delta. So where was this guy? At the same time when I was in medical school, he was flying helicopters between Cambodia and aircraft carriers off the coast, filled with narcotics, heroin. The U.S. had inherited the war from the French, who had lost a battle called the Dien Phu. We had taken over the war at that point, and one of the ways the French paid for the war, 1 was money from us, and 2 was selling heroin. And the CIA took over the heroin trade. This is well documented. So he got addicted to heroin, being a helicopter pilot. Heroin was given out to the troops in Vietnam like sugar. It was cheap, it was nothing, and everybody, 58,000 soldiers died in Vietnam. 3 million Vietnamese died. But the amount of addiction was quite high. And what he said is when he got back, he went through a lot of different programs. He just couldn't shake his addiction. He just couldn't try it. In fact, the last day he was, I saw him, he was still in prison. This is before he got him out. He got rearrested. I said, man, you can't figure out not to get arrested? You've done this like a million times. What's the scoop? And he said to me, Eric, what day is it today? Who cares what day it is? What difference does it make? He said, just, what day is it? I said, it's February 28th. I said, that's the reason. It's the end of the month. Have to make your quota on arrests. So he got picked up for walking his dog off his leash. So Juan spent half of a lifetime in and out of the New York State system. He wasn't an angel. He did a lot of stuff, mostly petty drug stuff and things like that. Because remember what happens to you when you become a prisoner, you essentially become socially dead in our society. You have no access to anything that citizenry gives you, and you end up living in an environment that essentially the drug trade is about the only thing that you can do to support yourself. And all of your associates are criminals, etc. So I got to know him and work with him and work with his wife, got very friendly with his kid. As a matter of fact, his son, this was a bad time of gangs in the Bronx. And his son, his father, I remember this conversation they had, his father was counseling him to join the army, to enlist, to not get killed, not have something bad happen to him in the Bronx, in a gang. And his son turned to him and said, Dad, hello, that's exactly what you did. Right? You went into the military, and now here you are. And so it's a very, very complicated, what options do people have? Gangs on the street, military, what happens in the military, et cetera, et cetera. The one-strike law. Let me tell you about another case, and we'll have some time for some conversation. This case is one of the most important to me, sort of personally. This case is called Beso de Angel, Angel's Kiss. It's the flavor of an ice cream in Mexico. It's called Beso de Angel. There's a, like Ben and Jerry's. So in Mexico City and around the area there, they have these stores called Tepos Nieves, which is like the Ben and Jerry's. And one of my favorite flavors is Beso de Angel. So there was a guy who got admitted to Bellevue from a Mexican guy who was working on a restaurant in Staten Island in the salad bar. He'd been in the States for 6 years. Lovely young man, very sweet. And he had developed some abdominal pain and went to a local hospital after it really, really bothered him, and some lymph nodes popped up. And he turned out to have, just to make a long story short, extensive cancer throughout his pelvis, invading blood vessels, and it was a terminal situation. He ended up getting treated on Staten Island, and the disease went away for about 6 months, and then it came back again. And when it came back, it was eroding through his femoral artery, the big artery in the groin, and it started to bleed. So the doctors on Staten Island did the right thing. They tamponaded put a lot of pressure on the artery to prevent massive hemorrhage, and they transferred him to us. So he comes over, and I got a call, we got this guy, because we usually don't take patients from other non-city hospitals. But I knew the guys out there, they didn't have the resources. So we took him. Unfortunately, there was no treatment for him except to amputate his leg. So he had an amputation called a disarticulation. It was very high, right at the pelvis. And then I went to see him, and there was nothing to do. He had cancer that was essentially the size of a football sitting in his abdomen, just pulsating. And the one thing he wanted to do was to go home. He had 3 kids he hadn't seen in 6 years, and his parents, he wanted to get home to Mexico. He lived in a little town in Morelos. It's about an hour and a half, 2 hours from Mexico City. And the question was, this guy's essentially his dying wish. Undocumented, 32-year-old, sweet guy, wanted to just be with his children and his wife. So what could we do? So I contacted the Mexican consulate, and the Mexican consulate actually is very, very generous amount of resources to help Mexicans get repatriated and to help in situations. The problem with this situation was he would need to be on a stretcher. They'd have to take out 6 seats on an airplane, and he'd have to have a doctor fly with him. Well, who's going to do that? And how are we going to get 6 seats on an Aeromexico flight to go back? So 2 weeks later, I'm on an Aeromexico flight, got 6 seats taken out, given him a morphine drip. My wife came along, and we got picked up by an ambulance at Mexico City, Benito Juarez Airport in Mexico City, and he got driven to Cuautla Municipal Hospital, spent 1 night there. He went home the next day. Doctor saw him every day. A nurse saw him every day, surrounded by his kids and his parents, and he lived for 1 more month. I just want to point out something. It's interesting. So he got picked up by an ambulance, and he got taken to a hospital, and he got home treatment. The United States does not have universal health care for all of its citizens. Mexico, 10 years ago, so say there's about 100 million Mexicans, decided it needed, because of human rights, it needed to provide health care for 100% of all Mexicans. And it started a program called Seguro Popular. It's like our Medicaid program. And within 10 years, they insured 50 million people who never had insurance before. Half the population did not have access. He got picked up by a Seguro Popular ambulance, taken to a Seguro Popular hospital, and treated by Seguro Popular medical staff. I couldn't do that in this country for 50 million people in this country. The other question with this patient, his name was Rogelio. With Rogelio was, why was this massive Mexican immigration north? What was going on socially, economically, politically in that country that is driving, until the most recent phenomenon of this extensive barrier at the border, north into the United States? What were the major drivers? And we had lots and lots of conversations. When I went down to Mexico, I met his family, lots of conversations with his sister, with all the in-laws and everybody sitting around, where half the family, the husbands or the wives, were in the States, separated and unable to see each other. But what were the drivers? What were the economic, political, and social drivers? And now, at this point, the narco wars, which have been devastating to that country. So I'll just mention the headlines of a couple of other chapters, and I'd love to hear some of your questions. I wrote a chapter on the obesity epidemic. It's called 4 Generations. This is about a patient's family that had 4 generations. The grandmother, the mother, her daughter, and her grandson had very serious morbid obesity with life-threatening consequences. And I get into chronic diseases like that, and then the food industry, and the influences on people, and what choices they have to say no or to change their habits. I have one case, a safety case. A woman got shot on the Lower East Side in her left groin, and she was bleeding out. So some guy was trying to steal her wallet. She refused to give it to him and just shot her. She got taken to Bellevue. And the issue there was, I got called in the middle of the night. The problem was, she got treated exquisitely. She almost bled out on the ambulance coming up First Avenue. But the issue was, and I said, why'd you call me in the middle of the night? One of my friends, he said, you gotta get in here, Matt. She got some bad stuff. She got 8 units of blood. The problem was another trauma case came in. A guy had his leg taken off by a taxi cab in Midtown. So this was Trauma Detroit. We call the patients trauma and then a city name, because you don't know, you can't identify them, you can't register when they first come in, you give them a fake name, like John Doe. This Trauma Detroit came in, she was the woman who was shot. At the same moment, Trauma Houston came in, and he had had his leg taken off. Brazilian lawyer. The problem was, Trauma Detroit got Trauma Houston's blood. There's a young girl named Tanisha who was from Bushwick and ended up at Bellevue. And I got called for her. It was interesting because they said, "Eric, you won't believe this. This young girl came to the hospital, and she came to our psychiatric emergency room, and she wants to get admitted." I said, "You got to be kidding. Why would she want to get admitted?" Well, usually it's you want to get unadmitted, right? You want to get out. So it was the story of this young girl and her trajectory through ACS services, through all the services of New York, multiple hospitalizations, all kinds of issues, and how she had managed to keep her life somewhat intact in spite of all the things that have happened to her. But the safest place, imagine this, you diagnose this, what's the safest place in the world is a locked psychiatric unit. Imagine what the rest of the world is. This young, half Dominican, half Haitian girl who ended up in our hospital. And I got to know her really well. She wouldn't talk. She was enraged, totally enraged. But I brought her paper, and she would draw. So the way she would express herself is through drawings. In my home, I have one drawing. She made this, most of her drawings were like atomic bombs. Emotionally, she was catharting out these atomic bombs. One wasn't, and one was a fish, a giant fish that looked like a horse, that had scales, and there was a couple on it, and there was a man and a woman hugging. And we did some forensic work, and we figured out that there was one couple that had taken care of her at some point in her life. That was a caring, loving couple that she had come in contact with. And the issue was, could we put that together for her again, so that she might be able to connect? Because this was all about her rage, not being cared for in her life. So let me end here, and hopefully folks have some questions or some thoughts, and we could have a little back and forth discussion. Really appreciate the time to talk to you. To me, the backstory was just as important as the patient story. So there's this medical trajectory, and then there are all of these other social and other issues. A lot of them which you guys deal with, and I'm sure you've experienced from other people that you know, but certainly the world that you're studying and the world that you're getting involved with is just filled with these situations, which are very, very common in our society, virtually all societies. Yeah.
My husband is a psychiatrist. He trained in downstate, and he was in the public health service doing residency during Vietnam. So it's a similar background to yours, and then went into private practice. The problem for him is that because he's, like, say, in a blue-collar area and a retirement area, that the government has huge controls on this. And what a person used to get a visit with the doctor, and he had regular patients who he saw, let's say, every 4 weeks. These were not deep therapy cases. That isn't what he does. But now the government has made it into a 15-minute visit, and they're talking about a 10-minute visit. I mean, they're setting standards that are truly not possible. The other thing is that he writes a prescription, people are on Medicare. I mean, it's become such a big business. He prescribes for one thing, the generic is for something else completely. The time and money used just to handle all the paperwork is just inconceivable. And I think that's a major problem. It's harder and harder for him. It's no longer as a physician that you can help a person, continue with them. People are given government insurance that a private practitioner cannot take because it's just not enough money to keep up with the high malpractice, even if you have no suits. It's such a big business. The drug reps come running in. I just thought you might address that. And also, one other comment, the difference between, let's say, Mexico, where they do all of that, the doctor is not concerned about malpractice. That's a very big issue for physicians now.
Well, just for those who might not have heard, this lady mentioned that her husband's a psychiatrist and discussed all the issues that are impeding his ability to practice psychiatry efficiently and effectively, and mentioned a few different things. So I have 2 chapters here on that. One is on this girl Tanisha, the child psychiatry issues, and the other is an adult case, which is called The Singularity. Schizophrenic young man who had basically obsessive belief in the end of the world coming as the singularity. But I think you're bringing up completely valid issues. The healthcare system in the United States is extremely broken. It's extremely fragmented. It's extremely siloed. The pieces don't talk to each other. It's much, much too expensive on the one hand, and on the other hand, there's not enough money for certain people to even stay in the game, if you're Medicaid, for example, because it just simply doesn't pay enough. The doctor would essentially not be able to pay his office staff, keep the office open, much less make a living. Forget malpractice. It's just living off Medicaid dollars. So the poorest part of the population gets, what doctor's actually going to, for example, one of the big flaws in Obamacare, and I basically support it. I don't mean this to be just picking on Obama by any stretch, but okay, so we're going to expand the access for 26 million people. Great, that's a really good thing, right? Exactly who's going to take care of these 26 million people? There's a medical school, hardly anybody's going into primary care. They're all going into specialties. If you graduate from medical school, the average debt of somebody graduating from medical school, I don't know what it is for you guys, is $175,000. Malpractice insurance ranges between $20,000 and $150,000. If you're an OB/GYN doctor, you have to work for about 5 months paying your malpractice before you have any take-home money. So I think your point's well taken. I think physicians are a lot responsible for the problem. They have abdicated the responsibility. They've made a lot of money, and they've left the leadership role. The drug companies are impossible. They have enormous wealth. They control an enormous amount of resources and sell many, too many drugs to an unsuspecting and fairly complicit population. That was my point at the beginning, that we're a drugged-out nation in a way. You see kids on Abilify, Seroquel, 2 other antipsychotic medications, another bunch of drugs for ADHD and an antidepressant. It's ridiculous. I was mentioning earlier, I gave a talk earlier, I saw a headline, and this is a very important message in this headline. The headline was, kids acting out in school is ADHD increasing? And then the other part of the headline was, no, change the parents' behavior. Whenever you see the kids doing something, looking in the wrong place if you're just looking at the kid. It's usually a canary syndrome. Coach Holting.
I have a couple questions about the psych ward.
Yeah.
I visited a former neighbor there after he thought he was going to harm himself, and he checked himself in, or he had himself admitted. And I guess there are 4 wards, and I went to the wrong ward, and it seemed like they had divided the patients as to how dangerous they were or something. Is there some division into the different wards?
The wards are extensively divided. We have wards where people who only speak Mandarin and Cantonese. We have wards for Spanish-speaking patients. We have wards for double trouble, like I mentioned, dual diagnosis. We at prison unit wards. Yes, so we have specialists. We have to do it that way. The patients are so sick, nobody has the remote capability of being taken care of all of these kinds of patients. It would be like having a heart surgeon taking care of a pediatric patient in the sense of mental illness. So you have to have it specialized. And the language issues, the cultural issues are phenomenally complicated. So yeah, people are divided up. Is it perfect? No. Are there errors made? Yeah, but in general, it's pretty thoughtfully done.
And how many different psych wards are there?
12. Huge.
And the other question was I agree with what you said about mental illness, the mental ill being some of the sickest people there.
Yeah.
And I'm just wondering whether you see any better treatments for schizophrenia coming down the line, because it just seems such a devastating illness.
You know, the irony is the medication that was invented for schizophrenia was invented in the 1950s. It's called Thorazine. What happened is the French were developing a drug to make patients who were going under general anesthesia a little sleepy. So they were looking for a drug that would make people drowsy before they went for a big operation. And they gave the drug to some people who had schizophrenia, who needed operations. And their hallucinations went away, and they became much calmer. And this was like a miracle drug. It then got bought by a pharmacy company in the United States, and it expanded its use over about 10 years, and they found it was extremely effective in treating hallucinating psychotic patients. Subsequently, they developed several other drugs, and in the last 15 years, there's been a whole, what they call second and third generation of drugs, antipsychotics. The problem is, all of these medications have side effects. Some patients have minimal, some have moderate, and some have severe. The newest antipsychotics' major side effect is obesity and diabetes. So imagine the trade-off. The other thing is, one of the major side effects from antipsychotics, the way they work, is Parkinson's-like symptoms. And when I talk to some schizophrenics on the drugs, they say, I can't take the drug. It gives me this feeling of a trembling inside that's so miserable, I just can't take it. On the other hand, for some people, it's life-saving and miraculous. So, complicated story. Is there something coming down the pike? Nothing soon.
I really enjoyed your talk,
Thank you.
and I especially like the idea that looking into one individual story that much detail and then connect that to larger issues. And I have some. I'm an anthropologist, and I have anthropology students here, and so I wonder if you'd like to talk a bit more about the process of collecting these data and selecting them. I mean, I'm calling them data, patient stories.
Yeah.
And your process of writing about these stories. And I don't know if you did further research about the social context as well.
So great question. So you flushed me out. I'm a frustrated anthropologist. In fact, just to tell you, I worked a long time ago with Arthur Kleinman and Paul Farmer. So remember I said I spent a year in Haiti? Paul Farmer was there at the same time. So Arthur Kleinman is one of the leading medical anthropologists in the United States and the world at Harvard. He's an MD, PhD. So what I did is I read a lot of anthropology, and my closest friends are head of anthropology at NYU. Fred Myers and Peggy Ginsburg are close friends. So my point, so I live in this world that any story you see, I believe in what I call the Rashomon effect, right? If something happens, you guys familiar with Rashomon? If you get a chance, see there's a movie by Akira Kurosawa. He's the leading Japanese director ever. And he wrote a movie, directed a movie, it's about 25 years old, called Rashomon. It's a character. What was fascinating about the movie, something happens. I'm not going to tell you what happens. Something happens in the movie. And then the movie's told from 4 different perspectives. And it's like there's 4 different movies told. It's beautiful. And so my point is, for these issues, there are multiple different perspectives. And I tried to get out of thinking of anything just from a medical perspective. I find it reductionist, boring, incomplete, and self-serving. I think I summarized that pretty well. So I was looking for the sociological perspective, an anthropological perspective, an economic perspective, et cetera, and trying to find different lenses into these issues. Because there's nothing, to me, sort of sillier than hearing a case presented and not knowing, what is driving. If the issue is congestive heart failure in that patient, why is she in Brooklyn? What is a woman from Rabinal Bahavera Paz doing in Brooklyn? What are all these people, what's going on here? What are the drivers? What did NAFTA really do? What did the Cold War do? What does it mean to have counterinsurgency as the doctrine in these places? By the way, way before Iraq and Afghanistan, right? So what are these threats? And let me just leave you with one of my, I'm very pro-anthropology, but this is something that's a very important statement by William Faulkner, one of the greatest writers who ever lived. And he said, you probably know this quote, "The past is never dead. It's never even past." And that is absolutely true. So what we're seeing play out over and over and over again is history played again and again. Vietnam War is the best case. We're seeing it played live in real action, just different. It's like if you watch the 18th rendition of a Sherlock Holmes thing done in modern times, still Sherlock Holmes, right? So now we're seeing these things done 50 years later, but it's the same old stuff, wine in bottles. So to me, you got to use an anthropological approach. Extensive notes, extensive interviews, extensive background reading. I talked to every expert in New York City. Fortunately, there were tons of them around here. Went to the country. That's why it took me a long time to write the book, to collect all the material. I did hundreds of interviews.
That was going to be my next question. How long will it take?
Long time.
Yeah.
I've been writing this book for 15 years. I mean, I started, but then I just put it together and I wrote it in a year. But I had boxes and boxes full of stuff. Sorry, apologize.
Hand up the whole
You're a
time.
small guy, a short guy sitting in the front row.
I'll stand up for you. I really appreciate your presentation. This is my abnormal psychology class here. I'm a psychologist. I'll actually be working at Bellevue soon in the next month or two. I think this is so important in terms of kind of having an understanding of different people's story. And I'm wondering, what role do you think the education system has in kind of creating an informed consumer? Because a lot of the disparities we see come from people not necessarily having the knowledge about the healthcare system, even as far as the Affordable Care Act, knowing kind of what your rights are within that, and what role does the education system play with that?
Good, really good question. It plays a huge role. One of the common themes here that I just want to use this question as a lead into is what's called the social determinants of health. Remember, we have all these patients with these medical problems, and the vast majority of their medical problems are not caused by a medical disease. It may be the proximate cause, like poverty. The woman who lived in a thatched roof and the kissing bug drops down, well, that's because she doesn't have decent housing. If you live in a decent house, you don't get that disease. If you can afford the good food and go to Fairway and go to Whole Foods and this and that, you don't have type 2 diabetes and you're obese, right, et cetera, et cetera. So of the social determinants of health, the list is poverty, 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 poverty. Okay, that's the first part. Then, education. A bad education system is a serious impediment to health and wellness and doing well. And then there are a whole bunch of other ones, and one of the other ones is addictions, and another one is mental health problem, and another one is a felony offense, and there are other ones, bad lack of social supports, et cetera, et cetera, et cetera. But the social determinants of health are the critical denominator in a patient's, all of my patients. But the education system, the lack thereof, the mediocrity of it in general, the unevenness of it. Let me make one other point. All of the things we're talking about are not equally distributed across the United States. You do a map. So you guys are in the criminal justice system. You've heard of $1 million blocks? You've all heard of $1 million blocks? These are blocks in your city of New York where prisoners on that block cost the city or state $1 million. You can do geo-mapping of New York City, and you can see which block keeps sending people back and back through reentry. There are patients in the United States, there's one very famous one called $1 Million Murray. He cost the city, he was in Denver, $1 million a year for getting cycled through the system. But if you look at across the United States, and this has been done, if you do a map of the United States and you want to see where the illnesses are, and you want to see where people get rehospitalized and where the costs are really high, and then you map it over a zip code map, that's a poverty index map, they're completely superimposable. And you know what the schools are like in those? 15% of the kids graduate from high school, et cetera, et cetera, et cetera. So these things all go together. So geo-mapping, there's a famous atlas called the Dartmouth Atlas of Healthcare. You Google it, you'll see a Rand McNally of health disease in the United States, and it's all, you can see it's completely uneven, completely pocketed in different areas, and you can predict exactly where those areas are. $1 Million Murray, $1 Million blocks, the lousy schools, the drug situation, et cetera, et cetera. It all runs together. Social determinants of health is the #1 driver of bad health. Diabetes, heart disease, early strokes, et cetera, et cetera. And it's funny, we spend the money on the delivery system, $3 trillion a year, 20% of our gross domestic product, increasing at 3 times the rate of inflation, but we don't spend it on the real drivers of disease. The health system is like the catch-up, the Band-Aid part at the end. We don't spend it on the school. We don't spend it on the neighborhoods. We don't spend it on the first 1,000 days of a kid's life, where you really need to put in the money. Kids exposed to all kinds of weird stuff at that age, they got it for their whole life, and they develop premature heart disease, obesity, and everything else when they're 30, 40 years old. That's the game. So we're in this funny warped world where we have this gigantic criminal justice system, but we don't deal with the proximate issues. We have this gigantic health delivery system, but we don't deal with the proximate issues.
I wonder if you could talk a bit about what does the billionaire's case tell us about quality of life? Because I'm not saying you're saying this, but one could easily believe a subtext in your presentation that says, you know, the poor, they get screwed because they're poor. And if they weren't poor, things would be better. And there's a case to be made for clean water, good education, better housing. But we're seeing this eruption, maybe it was there all along, in the abuse of prescription drugs. Some of us know that the upper class and the rich have a whole parallel system of health care. And most people don't know about it, that they struggle too. So if you can talk a bit about what's it like on the other side in terms of health care, and not so much the system to treat them, but the problems that drive them into that system.
Well, people suffer at every range of the socioeconomic scale. So suffering is not, let's put it this way, people aren't happier past a certain threshold of money. That's been well described, and it's about $55,000 a year. You ain't happy. One of the interesting things in the hospitals, you see somebody who's got very well-to-do and everything else in a hospital bed, and they have no visitors. You see somebody who's taxi driver, got cousins, family, wife, children, grandchildren. Guys, I had one guy, I remember he was laying on his bed, he couldn't move, he was in an accident, so they papered on the ceiling, he could see absolutely pictures of his family, his grandchildren, and people got cell phones, they're calling their family in every part of the world constantly. Let me tell you about one study, it's called the Whitehall study. It's an answer to your question. Whitehall is the street where the British government has all of its main office buildings, like Washington, D.C., the White House, and all that stuff. It's called Whitehall. It's in London. They did a famous study in the 1970s called the Whitehall study. All the British civil servants, they all have health care, they all have jobs, and what they did is, everybody who dies in Britain gets, in their death certificate, they tell in what class they're in. I won't tell you how they did it, it doesn't matter. But they graded what class they're in, according to their civil service status and some other indicators. And there is an absolute correlation between longevity and how high you are up. Even people who are way up don't do as well as people who are higher. So it depends upon what question you're asking. Are people happier? No. Do they have the same, stuff going on in their lives, and do they get divorced and they have this? Yeah. However, if you have more resources socioeconomically, you can avoid a lot of the stresses of life that get translated into high cortisol levels, epinephrine levels, early heart disease, early strokes, and things like that. And this gradation has been reproduced in 35 different countries all across the world. So the answer to the question is not a simple answer. People live longer, if that's your measure of a better life, living longer, then it matters. Happiness? Absolutely not. However, people who live in poverty generally have so much stress in their lives, and depending upon the neighborhood and the community, that it becomes a real issue in terms of managing social supports and good housing and appropriate food and things like that, then other things start to intrude on their lives. You asked me a tough one. At any rate, I think everybody's got places to run to, so I want to thank everybody very much.